Now it is my privilege to introduce our next session, the State of the State Fireside Chat with Deputy Secretary Pete Croughan of the Louisiana Department of Health. Dr. Croughan is an internal medicine physician with a background in health policy, state level administration, and addiction medicine. In this role as Deputy Secretary, he oversees the offices of Public Health, Behavioral Health, Aging and Adult Services, Citizens with Developmental Disabilities, Women and Community Health, and the 5 state-run facilities. Boy, Dr. Crowan, you have big shoes there. We are now going to have our fireside chat with Dr. Crowan. We'd like to warmly welcome you. I'll let you do your opening comments, and then we have some questions that we'll ask you and kind of go through. So, Dr. Crowan, welcome.
Thank you so much. Never a dull day at the department, but definitely excited to be here. I mean, I still see patients one day a week. It's been a priority of Governor Landry to make sure that he's got frontline practitioners in positions to make policy decisions. So I'm excited to talk through about this topic today. I think burnout and the challenges of the workforce are just a daily struggle. And for a long time, I felt like folks at the department up in the tall tower just didn't really feel the pain. You know, you ask for relief sometimes and it can 2 or 3 weeks. Well, 2 or 3 weeks of just daily struggle can really add up. So it's obviously a complicated topic and I'm looking forward to talking about it more. And like Governor Landry said, here y'all's ideas. I see this for me. I'm gonna take the privilege and jot down some notes as y'all make some suggestions. But looking forward to the discussion today.
Wonderful. Well, with that, we'll go ahead and get started. So, firstly, we'd like to know what is the Department of the State's priorities in regard to health outcomes for our citizens?
Sure. So Governor Landry gave us, I would say, three pretty clear philosophical charges when we started. That was to help people move from dependence to independence. It was to prioritize patients over bureaucracy, and it was to improve our health outcomes, to get a better ROI for how much we spend on healthcare, which our department is $19 billion annually and is only increasing year over year. So those, I would say those were that was our North Star when we came in, and now we had to figure out, okay, what does that look like in terms of actual content and programs and topic areas? Well, when we started in January of 24, the department was just actually wrapping up this process, which we call our State Health Improvement Plan. I, I hope maybe some folks on the call had participated in that. There was work groups all over the state, about 6,000 participants, asking the community what are the key topic areas. And that really identified three main areas. It was maternal health, behavioral health, and chronic disease. Well, that just happened to perfectly overlap with our charge from the transition team. So it was kind of one of those light bulb moments when we sat down and we were brainstorming, what are we going to focus on? Well, here we've got the governor and the community telling us the exact same three priorities: behavioral health, chronic disease, and maternal mortality. Unfortunately, we struggle in all three of these, and we can maybe talk about some specific initiatives, but behavioral health, maybe counter to what a lot of frontline providers uh, feel, and I do addiction medicine, is actually where we rank the best compared to peer states. We're usually in the mid 30s, which for Louisiana is, it's not bad. We're used to being in those low 40s on other measures. And a lot of that has to do with uh, relatively high satisfaction for folks once they're in treatment, but a lot of challenges navigating the system, bouncing between different levels of care, an over-reliance on inpatient and high acuity beds, and then no transition plan, often going back into a shelter or the community, ending up homeless or back in that hospital or jail. So the navigating the system is a big challenge, and we can talk about that a little more. On the maternal health front, that's where we're still pretty stubbornly near the bottom of the national rankings. Interestingly, the cause of maternal mortality has changed over time. When Bruce Greenstein, his first go around as secretary, prioritized the birth outcomes initiative, and with the PQC and a lot of great work, I think we really moved the needle on inpatient outcomes, especially mortality around the episode of delivery. but we had this thing called the opioid epidemic that unfortunately has more than overtaken the progress that we made in maternal mortality. And so now since 2018, overdose has been the number one cause of maternal mortality in Louisiana. So we've got a program focused on that called Project Mom, which I'm happy to talk about. And then on the chronic disease front, we struggle with both the prevalence of chronic disease and the management and the outcomes for chronic disease. We know we're 30% higher on stroke and heart disease than the national average. And on cancer, it's an even more interesting story. We actually do relatively well on screenings. We're fourth best in the country on breast cancer screenings. I think we're top 10 in terms of colorectal screening, but our mortality rate is actually almost the inverse. So we're, I think, fourth worst in terms of breast cancer mortality and bottom five in terms of colorectal mortality. So that's a couple part, some of that is catching diseases too late, screening when we're catching stage four malignancies, then we're gonna have a worse outcome. But a lot of that is also navigating the system again, time from screening tests to confirmatory tests or tissue sampling to treatment. And a lot of patients get lost in that follow-up. And just like with maternal health, we know that behavioral health plays a big part in that. So folks that are managing their schizophrenia, it's hard enough to get your colonoscopy lined up and then get your results and then get your follow-up test. It's even more challenging if you're, uh, have behavioral health challenges on top of transportation and everything else you're struggling with. So those are kind of the three big outcome areas that we're prioritizing.
Thank you for sharing that. Yeah, it's pretty consistent that our priorities are consistent and the same. So we have much work to do.
That's right.
So you've talked a little bit about this, but could you share or expound a little more? What are your concerns about optimal health for persons in Louisiana?
Hmm. Yeah, I mean, optimal health is one, it's definitely individualized. I think at the department we recognize that for everyone that might be a little different. But there are some definite themes where Louisiana as a state can make some improvement. And first and foremost is nutrition and food. Uh, we love our food. The great daily challenge we have is how do we keep our, delicious culture and make it healthier? And there's no easy answer to that, or we would have figured out a long time ago. But there's some simple ways I think that we can encourage healthier eating. And the mainstay of that is what is the government doing to subsidize healthy food or unhealthy food? And we know that 30% of our SNAP benefit was being spent on ultra processed foods and sugar sweetened beverages. In our mind, I think the inverse should be true. We should be subsidizing healthy food and not subsidizing unhealthy food. So the department, as of 15 days ago, just acquired 1,400 employees and the SNAP program from DCFS. So we're excited to be taking that on. So we're going to be managing EBT. We also took over disability determination services on the same day. That was an effort of, credit to the legislature to try to integrate some of these programs. 87.5% of folks on SNAP are also eligible for Medicaid. So we had these two different departments across the street serving the same patients. We have one that's paying for their food in a certain way, often leading to these chronic health conditions. And then across the street, we're the Department of Health trying to reduce Medicaid spend and make sure they get the care they need without being able to go upstream. So pretty excited to put those together and simplify the eligibility component. So that's going to be easier on patients instead of submitting the same information in three different portals. Often it doesn't change. And with that overlap, they should be integrated. So I would say food first and foremost. The other big component of that is our WIC program, which is really a national model for its ability to teach, healthy nutrition habits. It's one thing to show someone an artichoke, but if you never know how to cook an artichoke, then it's not gonna go very far. So we're gonna integrate those two programs and take some of the best practices from WIC and bring them over to SNAP. And then we know physical activity is obviously underutilized, especially in our youth in Louisiana. The data would show that it's not a primary solution, I would say, to obesity. This is kind of, I think, an evolution in the science that maybe many folks on the phone or on this call can appreciate. We used to think, exercise will drop weight. It's good for bone health, good for mental health, it's good for dementia prevention, it's good for blood pressure. But the weight is it really barely moves the needle on weight. So that's where nutrition comes in. But that combo, I think, is it's nothing new. It's not this isn't the first time folks have heard that nutrition and physical activity are the solution to overall health. But we're looking at what kind of barriers was the state putting up to prevent folks from achieving that optimal health? And I think a big one was subsidizing unhealthy foods because people are rational, intelligent consumers. I think that's our belief. And if you're looking at two different options and one's half the cost and it tastes a little better and things are stressful and you've got three kids running around and they're demanding it, like you're just gonna it's not a fault of them. That's how the system was set up to purchase that sugar sweetened beverage. So we need to do what we can, I think, to change the system and make it easier for patients.
Thank you. Well, that is a great segue for our next question for you because with the landscape across the country, have there been Medicaid cuts at the federal level which are impacting Louisiana's Medicaid populations?
Fortunately, the short answer is no at this point. I know folks have read a lot about the HR1, big beautiful bill. I think there was a third name for it. I can't remember, but that was just passed, which has a lot of Medicaid provisions in there. The earliest provisions that would go into effect are the community engagement or work requirements in December of 2026. So those haven't gone into effect yet, and I'll come back to that one. But the other aspects like the provider taxes and some of the other reductions don't even go into effect until 2028. So there hasn't really been any cuts at this point. Same with some of the other grant funding. This came up more last year, and we testified on this about some SAMHSA and CDC grants. The only one that really ran out was the CDC COVID grant, and that we had essentially spent, and we're not banking on that being renewed. And it was actually just canceled about 2 months earlier than we thought it was going to be canceled. So there hasn't been a ton of reduction. So that first one that's coming is work requirements. And I think it's probably, the one that folks are most worried about. I mean, I see patients with addiction that are on Medicaid, and many of them are trying to get jobs and can't find a job, and some can't work. So we're definitely coming at it with that patient-centered perspective. But I think if we do it right, we're pretty excited about this to nail it because one, there's a lot of exceptions in the bill, and I think folks may be familiar with it, but this is not going to apply to very vulnerable patients. So if you have mental health issues, substance use disorders, cancer diagnosis, if you're a primary caregiver, I think for children up to 15, maybe, there's a ton of exemptions in the statute. And then the state has a little more flexibility for defining further exemptions. The Another concern was, well, how's this going to work for shift workers or, we have a lot of seasonal workers. Well, the you can average the work over a period of time, and you only have to do the check before you check eligibility. So it's 30 days prior to an eligibility check that you need to show community engagement. Well, if 2 months prior was a high volume month and then nothing the month before, we can average that out and folks will still meet the requirement. So the goal is that no one loses coverage that is eligible for Medicaid. But I think there is a very small subset of patients, and I see it in my clinic too, that really want a job, I think would benefit from work. It gives them a sense of purpose. And so that's the exact subpopulation I think that we want to come off of Medicaid and on to commercial insurance, because ultimately that's the goal. And right now Medicaid is set up to have this sort of this cliff, going back to, patients as rational consumers. If they make $5 more and then they're gonna have to pay a huge premium versus paying nothing, there's a disincentive to make those extra $5. So we want to give people the support and work with the commercial insurers and the major employers to help folks move off of Medicaid onto commercial insurance, because our state unfortunately has, I think, the lowest labor force participation in the country. It's something like around 50%. So This is that place where work and health sort of totally intersect, but we're excited. I think we got to do this right. You know, it's a lot of work. I'm not going to pretend that but we're ahead of most states. There was a conference last week that Bruce went to, and a lot of places are just still waiting to see what happens. Well, we're already in there making design decisions and trying to work on our technology system. So, because things like how to upload and verify that work requirement, it should be as easy as possible. We don't want bounce back emails and complicated PDFs. So we're spending a lot of time thinking, how's it going to be as simple for patients to be able to upload that requirement. But big picture is, yeah, no big reductions in the short term.
Well, that is great news. And on this call or this meeting summit today, there are a wealth of expertise. We have most of our audience. I don't know if you were on for that, but um, most of them have been working for 20 or more years in their field. And a lot of that is nursing, social workers, health policy. So we have a lot of expertise. So our coalition also has the same priorities as what you're expounding upon with the state. And so
Mhm.
if there's anything we can do to collaborate, certainly we'd like to do that.
Mm,
So,
awesome.
with your experience and expertise in behavioral health addiction medicine, can you expound a little bit about what is being done? You said some, but a little more of what's being done to enhance behavioral health services and substance abuse prevention.
Hmm. Sure thing. I guess I'll divide it into programs and maybe workforce as kind of two big categories. So on the program front, we've got Project Mom and Bridge, I would say are two big ones that we're excited to launch. Project Mom is a reaction to that, what I said earlier about addiction being the number one cause of maternal mortality. Mom stands for maternal overdose mortality. And goal for that is to reduce overdose related maternal mortality by 80% in 3 years, which is a which is a big goal. It's an aggressive goal, but I think it's doable because we've got the constituent parts and we've gone around to different regions of the state, met with the local governing entities, met with the big hospitals, the birthing centers, community-based organizations, outpatient clinics. And a lot of people didn't know, oh, I can get Narcan here, or I have a peer navigator in my emergency department. I just don't know where to send them. And we've got a clinic saying, oh, I'm happy to see these patients. I just haven't been getting referrals. So we're doing a little bit of sort of wrangling at the regional level and then putting real incentives in there. So the department is totally overhauling our quality incentive program in Medicaid. And I think a big part of that will be providing support for hospitals to be able to build this infrastructure. So that's Project Mom. Bridge is a complementary program. It's actually building on the Lake Charles success story. It was the only part of the state that had a reduction in overdose while other parts went up. And it was a partnership between Imperial Calcasieu, the LGE, about 5 hospitals and the Office of Public Health there. And essentially, it's low barrier access. It's getting people in the emergency department on medication, giving them naloxone and connecting them to outpatient care. So we would never do this for like a heart attack. If someone came in with a heart attack to an emergency department, we wouldn't say, okay, please don't get that heart attack again, and then send them out with no treatment because we know what would happen. But we do this with overdose, unfortunately, all the time. Someone overdoses, they don't get the treatment for their overdose, which is for many of them, Suboxone is a very effective treatment. And then they go back out, and we know that the highest risk for subsequent overdose is within 48 hours after that ED visit. So it's a missed opportunity, and that's something we're gonna scale up. Ideally, every major emergency department would be able to have 24/7 access to someone who can prescribe bupe, have that patient leave with naloxone, and then have a warm follow-up. So it's not just a referral, but there's an appointment booked at an outpatient clinic. I think that's how we can really move the needle on that. But workforce challenges, I know that's kind of a theme for today, are especially difficult in the behavioral health space. So we try to do some low-hanging fruit just to free up some bureaucratic red tape, like we allow billing of provisional licensed LCSWs and family therapists last year. I don't know why we had two standards. There's plenty of provisional licensed other providers that we can bill for. And so we were asking supervising social workers to then go and repeat the same work that their trainee did. It didn't make a ton of sense. So we changed that, I think, within 3 months of coming in. And that's led to hopefully folks are seeing that, that benefit in their clinics. The other big thing is rates. We have to pay according to how much we value this problem. So last year, the legislature got $10 million in there for substance use rate increases. And then in this last session, we had an additional rate increase. And we're going to move to the ASAM fourth edition. So that's how we structure the levels of care for substance use disorder. So as we update our levels, we're going to be able to bring a rate increase. And the final component of that is SB 190, which authored by Senator Boudreaux from Lafayette. We that will move all providers up to 85% of Medicare in terms of reimbursement, all Medicaid providers. So that's for the first year, and then second year we're looking to get to 100%, assuming we can get that in the budget this year. So I think those programs and the workforce challenges are kind of or workforce solutions are the two mainstays of our behavioral health strategy.
Thank you.
No
Can you
problem.
identify any statewide data or trends regarding with the theme of our healthcare workers are so important in the theme of today's summit regarding stress or burnout or retention among healthcare workers?
Hmm. The data we don't have great data at the state level. It's something actually we're working on trying to get a better handle of it. The closest we can probably approximate is some of the data from the nursing schools that show how many folks enter wanting to be a nurse and then ultimately go into the workforce, and we show a pretty precipitous drop there. There's still a huge demand for nursing schools. And then, I mean, I guess I could ask any single person on this call, their take, and that's a pretty, like if we could do a digital raise of hands of who's either personally felt burnout or has their colleagues sitting next to them, I wouldn't be surprised if it was 100%. So it's it's a real challenge. The way I kind of think of it, uh, the science around burnout seems to be less about how hard you work or even the hours, because we've all had projects or missions or work settings where we really cared about the work and we're happy to work extra hours, or that weekend where you're just in a groove and you're putting in extra time and suddenly you look up and you're 14 hours down the road. But I think it's disconnect from the mission that leads to the burnout. So whether you're working 5 hours a day or 12 hours a day, if you feel like your priorities and your values are not aligned with the place that you're working, then that is a huge, huge challenge. So we're experiencing this in our state facilities. We've got two psych hospitals, two ICFs, and a nursing home, and that there's tons of challenges there. Part of how we're approaching it is reconnecting to the mission, removing some of the minor headaches, but really helping folks feel like they're part of something larger and that we're not just rearranging deck chairs on the Titanic, but we're making real improvements for the patients we serve. So we want to I think that's best done at the clinic level rather than the state level, to be honest. So we're trying to meet with health systems and outpatient clinics and figure out what do you need for your workforce? And part of that is relief. When everyone's asked to do an extra shift just because there's not enough staff, that's a huge problem. So how can we train more nurses? Very simply. The biggest probably moves we made on that is the Hero Fund, which I don't know if folks have heard about this, but we got an appropriation from the legislature to put out grants to different trainees to help uh, either do loan forgiveness or often funding nurse educators, because as many of you know, that's really the bottleneck with getting new trainees through is finding enough paying for the time of the educator. So we put out, I think, 21 grants, and three are supposed to go live at the start of 2026. So hoping that will be a successful pilot. And then we can go back to the legislature, maybe with y'all, and say, look look at the progress we made. Let's keep building on this momentum. It requires a match from the hospital, so it's not all taxpayer funding. But I think if that works well, and we're optimistic it will, could be a model for how we try to reduce some of the bottlenecks.
Great info. Thanks for that. Can you speak to how Louisiana is aligning with the national efforts like the Surgeon General's advisories or federal programs to support healthcare workers' well-being?
Yeah, I think it's probably, I mean, to me, it's kind of what I mentioned. I don't know if there's a specific Surgeon General program that we've launched. I think we need a Louisiana solution. I mean, I think they're really good at giving us the problem, but we knew the problem. The folks on this call knew how challenging it is. Yeah, we brought in a couple consultants and we hear the same thing. Well, you know, expand the workforce and reduce burnout. And we always just say the same thing. Okay, so how? Like what are the sub bullets? And then they say, well, that's for y'all to work through. So that's kind of our challenge. I think the advantage of the Hero Fund is it's homegrown and we get to look at these applications and we can differentiate an LSUE from a Loyola, from a ULM, whether that's a rad tech or a LPN or a CNA, and really try to reflect the demands on the ground. That's the advantage of having the hospitals participate is because Rapides can say, well, we're dying for respiratory therapists. And, Monroe might say, we're good, but I can't find a SLP, within 100 miles. And so we can try to, instead of a sort of sledgehammer approach, we can kind of try to target the individual regions and the demands there. So that's our goal through Hero.
Okay, great. You said a little bit, but we'd like to hear from our participants in the summit. What role do you see like for collaboration with us, with local governments, universities, community organizations in helping to shape health policy and promoting a culture of health?
Yeah, I I love things like this and any input we have, and I'll hope to leave my email. This since under Bruce, we've done more public sessions, and I think we've done more in 3 months than we did in a year and a half. And our our comms team, is like, oh, we're gonna do another one, but Bruce is like, we got to get out there, we got to take new ideas. So we did a quality and value convention over the summer where we brought in mostly stakeholders to give their input on how to design our Medicaid quality incentive programs. Excited that I think December. Let me get the exact date, but we're going to do what's called an annual shareholders meeting, kind of modeled after the Berkshire Hathaway shareholders meeting, where we think of Louisiana citizens as our shareholders. So they deserve to hear what we've done with the taxpayer funds over the last year and a half and get input on strategic priorities for the department. We've got a legislative healthcare academy coming up for legislators actually next week on Tuesday, where we're going to kind of prep for session and share a little bit about what the department does. And then I think in January, we're going to do a session called LDH Listens. And that's probably going to be the best or, most closely aligned with this. So it's sort of like it sounds. We, we, I guess our philosophy is that ideas and programs and policies that we come up with in our building without input from frontline providers often struggle within the first month. And we've tried this with other initiatives. So we, I think the best role of the state is to take ideas, kind of like the Lake Charles model with Bridge. They did that without the leadership supporting it. I mean, it was pretty grassroots. It was folks in the community that just said, "This is a need. We've got a solution, and we're gonna make it happen." And then I see our role saying, "Okay, Lake Charles figured it out. Like we need to scale this up statewide and recognize that Alexandria and Shreveport are going to do it a little differently than Lake Charles, and that's okay. But let's take those best practices and scale them up." So I would say if there's any of those types of examples where you at your clinic or you in a region or a parish have come up with an innovative model and think, look, this worked in St. Tammany, I think it could work elsewhere. Bring those to us because that's exactly the type of thing that we want to throw gasoline on and try to replicate.
That is great, and we're certainly eager to. So please do share that with us, and we'll help disseminate and get the word out and get our healthcare workers to participate in some of those meetings. So that sounds wonderful.
That'd be
So
great.
thank you, Dr. Crowan, for sharing your very candid and thoughtful overview with us on Louisiana's healthcare landscape. What we're going to do now is open the floor for questions from the audience. So please remember to submit your questions in the Zoom Q&A feature, and we'll get to as many as we can with the time that we have.
Perfect.
Claire,
Um,
it looks like we have a couple here. I'm gonna start with the last one that came in. And there's a question about will nursing be represented at the Healthcare Academy?
hmm. Healthcare academies more targeted for legislators. So that's kind of the primary audience and their staff. So I would say less at the healthcare academy. Although we should talk before session about ways to partner coming into that. Certainly, workforce and nursing will be a theme through those discussions, but I think no conversations about me without me. Like we're probably not going to, go too far down that policy road in that meeting. I think more LDH listens will be a good opportunity to get nursing at the table.
And then we had a question. I see this appeared again. At what stage are women overdosing related to Project Mom?
Hmm. Yeah, great question. So half the overdoses are in the postpartum period, and then the majority of those are within the first 6 weeks. And I think folks that see pregnant patients with SUDS sort of can relate to this. A lot of moms will not use while pregnant, but then you imagine the stress of delivering and then going home and often not even seeing a provider for 6 weeks, especially if it's your first baby.
Mhm.
Everyone just goes home, tries to figure it out. And then if you're in an environment where there's other people using, their tolerance is often low because they weren't using during the pregnancy and the compounding stress and mental health challenges. Unfortunately, that's the most vulnerable time. So there are overdoses while pregnant, but the majority is right in that postpartum period. And so, it's we talk about pregnant patients, but it will include up to 1 year
Yeah.
postpartum.
Okay. We have, let's see, another question here. What are the strategies around chronic care and how are advanced practice RNs and social workers being incorporated into that model for
Hmm.
delivery of services?
Yeah, great question. Part of it is I guess maybe a little philosophical is I think we want to set the strong goalposts for the hospitals and the clinics and not necessarily micromanage each chronic condition down to that level, but push them, especially if we're pushing out $19 billion dollars in Medicaid funding to really hit outcomes. So, as a tangible example, one would be better measuring time from tissue diagnosis to treatment for a cancer, for instance. So that's where we know a lot of folks drop off the map. There's tons of different strategies, whether you drive to someone's home and meet them in the house or just call them or text, or you have a community health worker or a social worker, that we kind of will leave up to the hospital or the clinic, but we'll set real aggressive signposts. And if they can't hit that, they don't get the incentive withhold. APRNs are going to be critical, especially in BH, but I know the questions about
Mhm.
chronic care, but I think they are the key to our BH workforce challenge in a lot of ways. But for for chronic disease, and I keep harping on cancer and malignancy, but I think that's where they play an underutilized aspect of the care team. We know that a lot of oncologic care is navigating the treatment and some of the side effects and long-term prognoses and thinking about life and how to manage family and mental health. And I think uh, I'm an MD, I'm biased. I think a lot of APRNs are better at that, honestly, than oncologists who went into the field because they love the chemo regimen and the science behind R-CHOP. And that's nothing against oncologists, but it takes both to treat the whole patient. And I
Mhm.
think that's where APRNs can really help.
Perfect. Let's see here. There's a question that just came in. There has been a lot of discussion on vaccines at the federal level. What is the position of LDH on use of vaccines and preventing disease?
Yeah, I think a lot of folks were following the ACIP meeting at the CDC, which uh, really the only big change was there's no changes on Hep B. There's recommending a provider consultation around on COVID vaccines. So we are taking that lead and implementing it. We still have vaccines at all of our public health units. I think the overriding philosophy, and you've heard this from the Surgeon General, is that it should be a conversation between a patient and a provider. And I think that is our guiding light. We can offer that at our parish health units because we've got providers there too. But um, that we just want to, I think, honor that doctor-patient relationship. We say doctor-patient, but we know it's not just doctors; it's APRNs too. So that's really the philosophy. I would say that it hasn't resulted in a ton of policy changes, other than that, we're in the post-COVID era, so public health is a big ship, and it's hard to move, and we really staffed up for the COVID response, and it's easier to keep doing the same things like large, you know, clinics and things like that were made a lot of sense in 2021, but in 2025, we're just trying to move on to other public health priorities, and we know we've got a fair number of even infectious disease challenges, pertussis, Vibrio, and pertussis is a great example where I think we've heard the Surgeon General talk about the role of Tdap, especially in that third trimester, which has really waned over the years, and so encouraging more folks to have that conversation with their provider, but not from the government standpoint coming in and mandating or requiring anyone to get vaccinated. I think we're allowing more of a nuanced decision there.
Okay. I think we have a couple more questions. I know we're getting down to our last few minutes here. There's one question. Have you heard of many hospitals pulling retired nurses back to help mentor nurses in the hospital setting
Hmm.
to help with retention? Just this
Yeah,
particular person had their hospital interested in doing that.
love it. I would say let us know if what we can do from the department standpoint. If there's a licensing issue, that's a great. There's so much knowledge out there, and folks are seeing their colleagues with these challenges and want to help. So we should make that easier, not harder. I think it's a great idea.
And then our final question, it said, I can appreciate the changes being made to the SNAP program. Will the state offer incentives that will bring farmers markets and/or grocery stores to underserved areas?
Definitely, definitely. I mean, uh, doesn't matter the quality of the food in a food desert if you can't get good, good healthy food. So that's definitely a priority. We've talked about food pharmacies with FARM as a way to integrate the
Mhm.
medical component and the growing component, and you'll see some policies coming out in Medicaid related to that. It's definitely a priority of this administration.
Thank you. Right.
What an insightful conversation. I'm certainly energized and looking for opportunities to get engaged. So hopefully our participants on the meeting today certainly are as well. Dr. Croughan, thank you so much for your leadership and for addressing the challenges and opportunities that really are shaping our state's healthcare future. Your focus on the workforce and its well-being, really as being the cornerstone of patient care, truly resonates with the purpose of our summit today. So
Mm,
thank you immensely.
mm. Well, thank y'all. I really enjoyed this discussion. This was pretty fun. And thanks for the hard work. I think it's those Friday evening phone calls from patients and the early morning challenging emails to sort through all those little moments that y'all do on behalf of your patients I know it takes a toll and cuts into your time with family and well-being. Just a huge thank you, because you probably don't hear thank you enough for all those little moments, and thanks for the work y'all do.
Thank you. Thank you, Claire, and thank you again, Deputy Secretary. We appreciate you joining us today.
My pleasure. Yeah. Have a great
All
rest of
right.
the day. Yeah.
You too.